Welcome to New Directions in the Management of Idiopathic Pulmonary Fibrosis, presented by Cedars-Sinai Medical Center at Res Insights Live. My name is Dr. Paul Noble. I chair the Department of Medicine at Cedars and also direct the Women's Guild Lung Institute, and I'm pleased to serve as the chair for this important educational program. Today's session is a live interactive program that allows us to take your questions in real time throughout this presentation. I encourage you to send us your questions anytime by typing them in the box located at the lower left-hand side of your screen. Joining me today to discuss new and very exciting directions in the management of IPF is Dr. Stephen Nathan. Dr. Nathan is Medical Director of the INOVA Lung Transplant Program at INOVA Fairfax Hospital in Virginia. Welcome, Stephen. We have a lot to talk about, so let's get started. These are my disclosures for conflict of interest. Idiopathic pulmonary fibrosis, a fatal disease of unknown etiology, affecting over 100,000 patients in the United States. There's an enormous unmet medical need. Just to give you a sense, there's 5 times the number of IPF patients compared to pulmonary hypertension. There's currently no FDA-approved medical therapy. Pirfenidone, however, is approved in Europe, Japan, and Canada. And the CAT scan here shows you the classic subpleural honeycombing of how we make that diagnosis. IPF does affect men more often than women. The typical presentation is in the 60s, patients presenting with breathlessness and cough. Therapy will likely need to be lifelong. It's a challenging diagnosis. Currently, lung transplant is the only therapy that prolongs life. This is what the biopsy looks like of classic usual interstitial pneumonia or UIP. You have to have areas of normal lung juxtaposed to areas of scar tissue formation. Now that we're getting CAT scans much more frequently, one of the things we're observing is that these early findings of patients with idiopathic pulmonary fibrosis, where you have these reticular opacities, and when you biopsy these, you see these areas of normal lung, and juxtaposed are these areas of scar tissue. And we think this is the critical area, this area called the fibroblastic focus, where we need to target our therapies. Unfortunately, IPF has a variable progression. Some patients progress slowly, but others very quickly. These CAT scans show patients over a 3 to 4 month period, the same patient exhibiting a marked increase in the fibrosis over a relatively short period of time. So therapies need to be effective quickly in this disease. There's a much molecular biology going on, and we really think this is a disorder that involves a communication failure between the epithelium that lines the lungs and the underlying mesenchyme or the fibroblasts. And this epithelium becomes dysfunctional and sends signals to the mesenchyme that leads to activating fibrotic pathways. And drugs really need to be able to target this communication. And here we see an example of a cartoon showing where these fibroblasts, which make collagen and destroy the lung tissue, get activated. So what we really need are drugs that target these pathways to try to prevent the progression of disease. Unfortunately, over the last decade, we've had a number of drugs that haven't worked. We've become very good at executing clinical trials in IPF, but we haven't had drugs that have been effective until what we're going to tell you about today. There have been phase 3 trials. This is really a watershed year for patients with idiopathic pulmonary fibrosis. What we're going to share with you are the results of 3 phase 3 trials. The ASCEND trial, which evaluated pirfenidone, Impulsus, which evaluated this multi-kinase inhibitor called nintedanib, and the NIH IPF-NET trial evaluating N-acetylcysteine. So in terms of pirfenidone has been studied over the last decade. It's approved in Japan based on a single phase 3 trial. There were 2 phase 3 trials sponsored by Intermune called the CAPACITY trial that looked at the effect of pirfenidone over 72 weeks. The primary endpoint was change in lung function or forced vital capacity. And what the results showed, one study met the primary endpoint, the other did not. Both studies, however, were positive through 1 year. The pooled data were positive, but the FDA did not approve the drug and asked for another trial. Based on these trials, however, the drug was approved in Europe and Canada. So ASCEND is a randomized, double-blind, placebo-controlled trial, 550 patients, randomized 1-to-1 to receive either pirfenidone or matched placebo for 1 year. Importantly, it was centralized review of the high-resolution CAT scan, surgical lung biopsy when performed, and spirometry. And in addition, deaths were confirmed by a separate committee, and the eligibility was done to ensure high-quality efficacy assessments. There were a number of sites, and it was multinational. The primary endpoint was change in forced vital capacity from baseline to 52 weeks. And the statistical analysis is what's known as the Rank-Ankova model. However, to assess the magnitude of the effect, it was a categorical analysis. What this meant was what percentage of patients lost 10% of their forced vital capacity or didn't decline at all or died. We know this 10% loss is clinically meaningful. Key secondary endpoints were walk distance and progression-free survival, defined as either a loss of 10% of your forced vital capacity, a loss of 50 meters in walk distance, or death. Additional secondary endpoints were all-cause mortality and treatment emergent IPF mortality and dyspnea as measured by the UCSD shortness of breath questionnaire. The eligibility criteria are shown here. Again, the critical point was it was a central review of the high-resolution CAT scan by experienced radiologists. In addition, we also modified the previous entry criteria from capacity to try to enrich for patients who would progress. And one of those criteria were lowering the DLCO from 35% to 30%, but also having patients with an FEV1 to FVC ratio of 0.8 or greater. This would exclude patients with severe emphysema, but also enrich for patients with more restrictive disease. Here is the primary efficacy analysis. And what you see here is over 1 year, you see there is a 50% reduction, or 47.8% reduction in the decline of forced vital capacity with a highly statistical p-value. So patients taking pirfenidone had a very different experience than patients taking placebo. They had a 50% reduction in the likelihood of losing that 10%. Here, this is shown differently in different graphically form. You see on the left hand, there's nearly a 50% reduction in your likelihood of losing that 10%. But interestingly and very significantly, you see there was a 132% increase in your likelihood of not changing. And we know that when we see patients for the first time with a forced vital capacity of 65 or 70%, if that doesn't change, they're going to be okay. Key secondary endpoints was this walk distance. We know from previous trials that if you lose 50 meters or more, it correlates with worse morbidity and mortality. And what we saw was that patients that took pirfenidone had a 28% less likely chance of losing 50 meters over a year in their walk distance. And this was statistically significant. Similarly, the progression-free survival, remember, either losing 10%, losing 50 meters of walk distance, or death. You see that the hazard ratio of 0.57, that means you were 43% less likely to have one of those bad things happen to you. Interestingly, we also pre-specified to look at the mortality in the ASCEND trial and pool with the capacity trial. And the study was not powered for all-cause mortality, but what you see here is a p-value that is not statistically significant, but a hazard ratio of 0.55, meaning you were 45% less likely to die during the course of the trial. And if you look at treatment emergent IPF-related mortality, that is the investigator at the site thought the patient died of IPF. Again, you see a hazard ratio of 0.44. The p-value is not statistically significant, but trending in the right direction. Here we look at the pooled data. So this here 1,200 patients in these three trials, looking at mortality. and you see the hazard ratio of 0.52.